Welcome to BDI Briefs, where we take a brief look at important issues about the emotional side of diabetes. Thanks for joining us today. I'm here with Dr. Bill Polonsky, president of the Behavioral Diabetes Institute, and Dr. Susan Guzman, director of clinical education at the Behavioral Diabetes Institute. Both are world-renowned diabetes psychologists and two of my favorite people to talk with. My name is Scott Johnson. I've lived with diabetes for almost 45 years and have been active in the diabetes social media space and industry for a long time. With introductions out of the way, Bill, what are we talking about today?
Thanks, Scott. There's so many new papers out. And this one just came out a few months ago, came out in one of the journals from the American Medical Association. And we'll put up the slide. You can see the title of this article, which is called Glycemic Control with Layperson-Delivered Telephone Calls versus Usual Care for Patients with Diabetes. Now, Susan, my colleague, is the expert at helping us understand what are the right words and words not to be using these days. And of course, just that title is full of things that hopefully we're going to start changing. But that is the title of this article. And what this article demonstrates, something that I think we really agree is so important and so critical. And what they did is they included more than 260 people with type 2 diabetes. What's important to know about these people is that, first of all, they were very poor. These were people who had, I think about 90% of them had an annual income less than $35,000 or $40,000, if I remember correctly. And they all had pretty high A1C. I believe the average A1C was about 10%. Mm-hmm. So these people, could obviously benefit from some kind of help to help them get to a safer place with their diabetes. And what this investigation did is they hired and trained a bunch of community folks and trained them to do what many of them could just do naturally, to really be empathetic, to be good listeners, and to be, as helpful as they could possibly be, along with some minimal training in diabetes and diabetes education. And they encouraged them to have regular phone calls with these, 260 folks with type 2 diabetes. To be fair, I shouldn't say correctly, with half of those people. Half of them were just in, quote, usual care, so they got no phone calls. But the other half engaged regularly with these helpful, empathetic, regular lay folks over the course of 6 months. And what they found, which is what you're going to see on the next slide, was, pretty impressive. Now, this looks a little messy, so let me explain what you're seeing here. What you see in the first two columns, when you look at just generally the usual care group, it's about 130 folks, versus the second row, which is the intervention group. Both of them started at about 10% A1C. That's the first column. And if you look over at 3 months and then at the 6 months column, you can see that there's already a sizable difference. And the next column, that's titled Change at the very top, you can see the usual care group had an improvement. I could hate to call it an improvement in their A1C. Actually, I shouldn't say an improvement. It's actually worsening of 0.02% increase in A1C. It didn't really move. While the intervention group had a decrease of 0.7%. That's very impressive. And this was a highly significant difference. So just this intervention mattered. Just actually asking these and training these nice lay community people to make regular phone calls and let the folks with diabetes know that we're rooting for you. How can we be of help? What are you struggling with? What's tough? Let's talk about it. Didn't mean they had any necessarily great solutions, but just knowing there was someone out there who could lend an ear and care. Now, in this study, they did one more thing, which is what you see in the rest of the rows. And if you look at that very first column, they divided people up into whether they had, I hate to call it this, but I'm going to say quote unquote depressed mood, because they had scored higher than a score of 5 or higher on a very commonly used questionnaire called the PHQ-9. And they compare that to people who scored less than 5. And that means clearly these people don't even come close to how we would define depression. And really what you see, I'm not going to go through everything in the slides, just to say, you see the biggest benefit for those people who had elevated depressed mood. So those people who scored above 5, which is the last 2 rows, that's where you see the biggest difference. So those people with depressed mood had more than a 1-point drop in their A1C. And those people in the usual care group who also had, again, somewhat depressed mood, there was pretty much no change in their A1C at all. And there really wasn't much of an effect in those two middle rows on the screen of those people who had a PHQ-9 less than 5. Really not much of a difference. Both of them showed some benefit, but really nothing like that. So what do we conclude from this? Well, let me read what they actually said in this article, and I'll have it here on the screen for you to see as we read it together. The goal for this project was not to accomplish tasks, but to converse, to learn more about the patient. Patients chose the frequency and length of calls, and they discussed their own interests. When they expressed needs, which they were more likely to do because they were being called regularly by someone we believe, trusted, patients were supported in connecting back to the health system. And this reversal of focus, starting with patients on their own terms, may increase their sense of autonomy, enabling healthy lifestyle changes aligned with personal preferences. Now, that's kind of worry. I really think what this tells us is this. If you're someone living with diabetes and you already have a lot of other stuff going on in your life that are already making things difficult, like you're not making very much money, and you may have some depressed mood on top of it, when you got somebody in your life who's rooting for you, it can make all the difference in the world to be able and willing and have the interest, even bandwidth, to take on the effort and tasks of trying to manage diabetes more effectively. And it's this ineffable quality that we don't talk enough about in diabetes, the sense that how nice it is to have somebody in your life who's rooting for you. That could be a healthcare provider, which should be many of the people listening to us right now. It could be a family member. But how we understand that and how we support that, I think, is really critically important. So let me turn it back over to Scott and Susan. This is a topic I know near and dear to both of your hearts. What do you think of this? Comments, thoughts?
I think it's very interesting and very much, you summed it up perfectly. Just simply knowing you've got someone in your corner rooting for you that cares how you're doing can make such a big difference in everything.
It helps front burner it, I think, too. It's that for the people who have these elevated A1Cs, they're not engaging very effectively with their diabetes self-management. And I think having someone call you up and express an interest and care about you as a person can help front burner it. I think the other really important thing about this is that these were not mental health professionals doing these interventions or other healthcare professionals. These were lay people. And I really feel like that helps promote our message, which is that we all have a role in helping people feel supported. It doesn't have to be a healthcare professional that provides that service.
Yeah, that's so well said. Thank you. Now, I have to pick on Scott because, Scott, you're our expert here, right? You've been living with diabetes for a long time. Have you ever had that experience? Has there ever been someone in your life where you felt it was rooting for you that helped you to stick with diabetes when it was starting to feel really old?
Absolutely. I would say, this, it really makes me think of the value that I have found in connecting with other people living with diabetes, in my case, through usual social media channels, but that also evolved into in-person meetups and things like that. But someone who can understand and relate, and even though many of the things that we're struggling with are similar with diabetes, everyone's unique. And so there's, it's all individualized there, but just having someone that you can talk to, whether that's over the phone or over the computer or what have you, I definitely made a difference for me and continues to make a difference.
Yeah. So if you're a healthcare professional listening, remember that's a part of your job now, right? It isn't just taking unproductive medication for your patient, but they need to know that you're rooting for them. And how do we convey that? Or how do we do that in a way that makes a difference? And we've certainly learned a lot about that over the years, but we all have to just focus on it and keep thinking about it. So that's all I got. Scott, take it home.
All right. Well, big thanks to everyone watching, and thank you too for always just shining some light on these great hopeful messages in diabetes care. It's refreshing to talk about positive news, and I'm excited to share more in our next episode. We'll see you then.